Okay, thank you. So I'm honored to be able to participate in this program. My name is Patricia Keegan, and I am the director of the Structural Heart and Valve Center in Atlanta, Georgia. And again, thank you to Amy Johnson and the team from Rock the Heart for inviting me to participate. Organizations that provide access to information and patient empowerment are needed partners in the healthcare journey. I thank you all for taking the time to participate and share your knowledge and stories. So when you think of Atlanta, which is where I'm from, perhaps you think of some of our teams. Maybe these are some that you might be familiar with, our World Series champion Braves or our Georgia Bulldogs. However, I would like to introduce you to our Rockstar team. I think it's amazing that this team has a shared true north, which is helping patients regardless of job title, function, or background. So what is a team? So I know this definition is very textbooky, but what it says is true. The team needs to work collaboratively with the patient. We describe this model of care as patient-centered care. As well, much of what we do on the structural heart team is to work with the patient on shared decision-making. Much of this occurs in collaboration with the patient and the team. The patient is the chief decision maker of their care, and our job as the team is to provide the information for the patient to make the best decisions for them. What we want the decision and what we want the team to do is to provide safe, effective, patient-centered, timely, efficient, and equitable care. By definition, the team is more than one person making a decision. The team, in essence, works for you, the patient. You have an entire team that is invested in your health and well-being and here to guide you through the process of making decisions regarding your health care. Having clinicians of different backgrounds, education, and experience can provide expertise on various aspects of your care. What do you need to know pre-procedure? What do you need to know during the procedure? And how can your recovery be successful? We all want what's best for you. I made sure to include some important milestones that are with my team. Number one, we have a female cardiac surgeon who also trained in interventional cardiology, and we had our first all-female TAVR team. So our interventionalist, our cardiac surgeon, our anesthesiologist, and our fellow were all females. We have an amazing cath lab staff who helps guide you through the process, as well as our team of nurses and ultrasound techs and imaging techs who help make your process much easier. So why do we have a team? The team model is really good for everyone. We see higher quality and positive patient outcomes. Obviously, these are important to all of us and our patients. Right now, having a work-life balance and decreased burnout is essential for our healthcare providers. Working in teams evens out workloads and decreases burnout. So what we see from this diagram is that we want increased efficiency because we all want to be able to move through the system safely and efficiently. We want quality care, and of course, we want positive outcomes. We know that getting patients through the system and being able to treat them safely and efficiently helps to have better outcomes. So why do we have team-based care? So in 1999, there was a report that came out from the Institutes of Medicine called "To Err is Human." What many of us remember about this report was the number of medical errors that were responsible for patient harm each year. And what they showed was that this number was astonishing, somewhere between 44,000 and 98,000 patients per year. In 2001, the Institutes of Medicine released a second report called Crossing the Quality Chasm. In this report, the Institute of Medicine recommended 6 aims for improvement. And these were kind of guides that told us what should we be focusing on to improve our patient care. The aims were safety, effectiveness, equity, timeliness, patient-centeredness, and efficiency. Working with teams helps to achieve these aims. In the early 80s, two important studies showed the benefits of surgery versus medical treatments in stable coronary artery disease. Both these studies used the heart team, and this included a cardiac surgeon and a clinical cardiologist. And what they did is they selected patients for eligibility and randomization. So this was really, as they say, dogs and cats working together, or just opposites attract, so to speak. And so what we did is we saw with these patients that the teams work together, and they showed that the heart team minimizes poor outcomes. It helps to grow our culture. And so it also minimized errors and facilitates evidence-based decisions. In 2016, a survey among involved physicians, the most important characteristics of a heart team were as follows: collaborative, multidisciplinary, beneficial, necessary, and positive. And I think that's some really good insight about being part of a heart team. We saw a lot of these teams originally in transplant and oncology. We had nurse navigators, we had social work, we had separate specialties that were working together, even pharmacy who participated in the care. So again, we had a lot of guidelines to show why this is the way that we should have been moving. When it comes to teams in TAVR, what's really interesting is the original trials when it came to structural heart interventions had the surgeon and the interventional cardiologist evaluate, treat, and provide care for these patients. And then in subsequent trials, we actually saw that these patients, again, we kept these components of the trials. We had research who participated in this process, imaging from patients who underwent echocardiograms or CAT scans, anesthesiologists, our cath lab nurses, our staff nurses, advanced practice providers became involved. This was also where we really saw the advent of the valve clinic coordinator. And this was really the start of the multidisciplinary team for valve patients as we know today. So when we look at our multidisciplinary heart team, we saw that through industry, they were really the big creators of, really kind of guiding and looking at our expertise from the heart team. And so what first came out was that the members of the heart team, again, include the referring cardiologists, the coordinators, surgeons, interventionalists, our cath lab staff, and all of these came together. But really, one thing that we also really came to include was the patient. The patient is an integral member of our heart team. It's the center to which all the other pieces come around. So for this particular diagram, I really like this depiction of the heart team from Brennan et al. It has the patient in the center, and it includes our medical colleagues. But then what's really important is it also includes the patient family. And when we talk about the patient's family, we don't necessarily mean blood representatives or blood relatives. What we talk about is family is whoever the patient says family is. And this is really important in patients' recovery. It also includes other specialties. Maybe if you have kidney problems or lung problems, we include this team. We also include rehabilitation. So when we talk about cardiac rehab, they are definitely a part of your heart team as well. So let's think for a minute about who impacts your care. As you can tell from this slide, there's lots of areas of people that affect your care. This list certainly is not exhaustive, and you may come into contact with or have a part in your care. Some of you may never see, like the insurance team or the scheduling team. But what we do see is when you think about when you walk into your doctor's office, who do you see? Do you meet the medical assistant, the front desk clerk, the check-in, check-out person? They're part of your team. When you come in for procedures, our admissions colleague, the nurses, the physicians, our advanced practice providers, dietary, environmental services, they're all part of your team. When you go home, your team at your local cardiologist, at your cardiac rehab center, your family. They're all part of your team as well. So when we talk about guideline-based care, there is a number of organizations that help guide medical practice. And this isn't just for cardiology, it's for a lot of disciplines. In the world of cardiology and in cardiac surgery, we do have a number of organizations. These are the American College of Cardiology, the American Heart Association, the Society of Thoracic Surgery. And so what happens is sometimes they come out with these recommendations. And so we do know that a lot of disciplines are involved with patients undergoing heart valve surgery. Over the past few years, these organizations that focused on heart disease have worked to put together these guidelines to guide the care of our patient. Guidelines give general recommendations of how to perform a task or advise on how to proceed in a situation. The American College of Cardiology and the American Heart Association are just two of the organizations that help serve as patient advocates and guide our cardiology practices. In the past number of years, they have put out a number of recommendations or guidelines when it comes for the treatment of cardiac disease or valvular heart disease. And so at the end of 2020, they came out with these guidelines for treatment in patients with valvular heart disease. So when we talk about the guidelines, we obviously want to cover what we saw in these guidelines. So the top circle here looks at evidence, strength, and then the recommendation. So the COR is a class of recommendation. This is the strength of the evidence. LOE is the level of evidence. This is the quality of the data. And for this, we look at research trials and expert opinion. In our guidelines, the organizations state that having a multidisciplinary team is necessary, and you should see patients being considered for valve procedures. As we read papers, we look at to see if the paper is scientifically sound. This statement was made with a strong level of evidence and expert opinion. So what does this mean for our patients? If you go to your provider and you have a heart murmur, and that heart murmur comes back and it says you have aortic stenosis or mitral valve disease, if there's any consideration that you might need treatment, sending patients to a multidisciplinary heart valve team is clearly recommended by our guidelines. When we talk about the second item here, we talk about indications for transcatheter aortic valve implantation are expanding. And this is as a result of multiple randomized trials of transcatheter aortic valve implantation versus surgical implantation. The choice of type of intervention for a patient with severe aortic stenosis should be shared decision-making process that considers the lifetime risks, the benefits associated with the type of valve, and this means just mechanical versus bioprosthetic valve, and the type of approach, transcatheter versus surgical. We still are continuing to work on gathering data on this section, but again, going to a heart valve center is reasonable when it comes to these treatment options being discussed. So how certain are we that the heart team should be involved in your care? Well, what we did as an organization or as a government is we tied payment for these procedures. So there's something called the National Coverage Determination. And this is what it is, again, going back to what we talk about guidelines, is Medicare guidelines for participating hospitals to get paid for doing the procedures. The committee saw the evidence and believes that the heart team is essential to care, that they included having a heart team in their rules for payment. Per the ruling, the heart team is not just a one-time meeting. The heart team is involved in care throughout your process and the patient's treatment. This includes pre-procedure, during the hospitalization, and even post-procedure. The collaboration became so essential that in 2012, the Centers for Medicare and Medicaid Service, which is called CMS, mandated a heart team approach for all patients receiving TAVR as a prerequisite for reimbursement. This was continued when the guidelines were updated in 2019. For patients with coronary disease, the European Society of Cardiology guidelines recommended this concept as a Class 1 indication, which means that it's highly recommended. And as the in 2010, and then the US guidelines followed suit in 2012. So when we know what must make a good heart team, so there's components of a heart team. And so the teamwork must provide an atmosphere of trust, positivity, cooperation, and effective communication as necessary components of making the team successful. Trust is the underlying foundation of any good team, not just the heart team. Without it, no team can succeed. Furthermore, having a positive attitude is key to help solve problems rather than harbor them. Cooperation and effective communication is necessary overall for leaders to role model and teach, which encourages our staff to climb on board when tackling new initiatives or projects with a team attitude and an optimistic perspective. Time and time again, teams outperform individuals because they generate enthusiasm and high energy. So when staff works together to achieve and deliver results, patients have improved outcomes. When we talk about care models, it can be a little complex, and we like to put together big fancy graphs and things like this, which is what you see here. But what we know is that patients who have any kind of issue, we can't just do it alone. It has to be about more than just a procedure. We see that in this chronic care model, not only does it include the health system and the decisions that we can help with, or our information systems, tracking medical records or what our process is, but even working within the community to how we can help you be a success with dealing with any medical issues. We have informed, activated patients, which means that you have the tools that you need to be successful and make decisions. You also have to have a good practice team who wants to have productive interactions. And this goes both ways. It's not just a physician or a advanced practice provider or a nurse telling you what to do. It's what do you feel is right and how do we work together to get those great results. When we all work together, we have improved outcomes. So here we're just going to talk about kind of putting models into practice. We've talked a lot about the role of the team, and we've talked about what makes a good team, and that, the guidelines suggest that there's a team, and even we need to have a team to get paid for doing these procedures. And so, but what does it look like when we put it into practice? And so this paper by Wang and team looked at the relation of post-discharge care fragmentation and outcomes in TAVR implantation. And this was from our national registry, where the data goes into about patients and outcomes. And what this paper actually looked at is patients who were discharged from the hospital after having TAVR. So what did they see when they wrote this paper? Well, number one, the authors looked at patients who had transcatheter aortic valve replacement between 2012 and 2015 at 374 sites across the United States. Then it looked at what they called fragmented care. And fragmented care was defined as if a patient had to go back to a hospital after they were discharged from their TAVR, that they went to a hospital that was different than the one who did their TAVR. Most patients, unsurprisingly, received what they called fragmented care, and that was 57%. And these patients had higher rates of readmissions and illness at 1 year. So this was, having your TAVR at one center and then seeking care at someplace else. That was, honestly, this was most of our population, and it was noted to have increased mortality and all-cause readmissions. The longer driving times were associated with higher rates of fragmented care. So if it took you a long time to get to the hospital where you had your TAVR, that you'd want to go someplace close, right? So lastly, there was an unequal geographic distribution of TAVI volume. So that meant that there were centers that were not equal, that they were harder to get to, longer to get to. Some states may only have one TAVR program where other ones have 40. So how do we make this care accessible to all? So how do we fix this? So your heart team needs to coordinate with your local team and your support team. We want patients to be taken care of locally when possible. And how does this happen? Our teams need to be aligned. After all, we have the same true north, which is your care. We have physicians that are designed to help you recover and know where you can seek help. Sometimes this can just be knowing who your family should call, or getting your medical records where they need to be, or making sure your social support knows how to best provide care when you recover. This includes cardiac rehab as well. So this problem, it showed it was a problem, but our team, we have to work to fix it. So what's the first step? I did what everybody does, and that's I Googled, how do we have a successful heart team? Unfortunately, no easy answers came up. So the second thing, I said, well, okay, what makes a good team when I changed my search? I'm not only looking for a good heart team, but a good team in general. In a real team, all members have shared goals. There's interdependency, so we rely on each other. And it's not easily achievable when multiple specialties are involved. And for that reason, the heart team can only perform its purpose if it becomes a real team whose decisions are not based on hierarchy, unbalanced information sharing, or hidden agendas. Best practices recommend a standardized heart team meeting, a protocol with defined timeframes, leadership, role of team members, discussion culture, and process of decision making. If these evidence-based recommendations can be adopted, optimal decision making and optimal patient care can be achieved. So what makes a great team? You have to have knowledge. You have to know what you're talking about. You know how to treat patients, and you have that insight. Cooperation, sometimes it requires some negotiation. Flexibility, how can we meet our patients where they're at? Common goals, we all have that same true north, and that's excellent patient care. Dedication, I think you'll find that people who work in structural heart disease and cardiology and heart valve are some of the most dedicated individuals. You've seen them with speaking here today, and you're going to continue to meet them upon your journey. And as I've been reading the Whova app and seeing a lot of the commentary, I can see that that's true. Planning, sometimes it takes some time and effort to know where you have to go, what time you have to be there, and all about the medication. And then effort by all. So how do we come across as, everybody pitching in to make sure that patients have excellent outcomes? So when you go to a center and you're looking at what that team looks like, make sure that they have elements of your team. Together, everyone achieves more. So I'm not sure that Taylor Swift is as lucky as Grand Funk Railroad to play for you all tonight. However, as Taylor Swift would say, there is no I in team, but there is a me. We all need to play our individual part in making this team work. Collaboration, knowledge, and participation are all needed, as well as making sure the patient voice is heard. You are the center of the team. So with that, I want to thank you. Thank you to Rock from the Heart for inviting me to take part in today's presentations. Thank you to the survivors, patients, and caregivers for sharing your stories. We will all become better by listening to each other and learning from our stories. I appreciate the opportunity to continue to learn from you all. Thank you for sharing your heartfelt messages. It's been very much appreciated, and we all look forward to growing together. Thank you for your time.